Good afternoon, everyone. My name is Emily Krause. I'm a senior program officer at the Bob Woodruff Foundation. We've had a really great turnout for this event, and we welcome everyone this afternoon. For those who are not familiar with the Bob Woodruff Foundation, our Got Your Six network is the largest non-governmental network of organizations serving our military and veteran community. The network is made up of veteran serving organizations of varying sizes, maturity, and focus areas across all 50 states, Puerto Rico, American Samoa, and Guam. We are a thought leader, a funder, and when it's helpful to our community and when we're trying to understand thorny issues, we're a convener. Before we begin our conversation today, I wanted to pull up a slide with some baseline facts about the aging veteran population to help ground our discussion. Give everyone a moment to review these, but I think they really underscore the importance of having this conversation now and being forward thinking about future solutions to serve this population. And now I'm excited to introduce our panel and kick off our discussion. We are joined today by Amy Fairweather, the Director of Policy at Swords to Plowshares. Dr. Melba A. Hernandez Tejada is an associate professor affiliated with the Trauma and Resilience Center at UT Health Houston. Dr. Annika Pless-Kaiser is a clinical research psychologist in the Behavioral Science Division of the National Center for PTSD and a research assistant professor of psychiatry at the Boston University School of Medicine. And Nathaniel Saltz is the Chief Program Officer at the Minnesota Assistance Council for Veterans. Thank you all very much for lending us your time and your expertise today. The first question I have is for the whole group, but we're going to start with the big picture. What are the challenges and considerations for aging veterans in your specific community?
I just quickly wanted to note I'm not here speaking on behalf of VA, but I'd love to speak about some of the work that we're doing, some of the programs that I'm aware of, and just to think a little bit about some of the important considerations for aging veterans. We think a lot about mental health conditions, so things like post-traumatic stress, depression, anxiety disorders. We think about physical health conditions, chronic diseases, heart disease, cancer, COPD, frailty. We think about things like suicide, as well as cognitive decline and dementia. So these are a few of the big areas that we're thinking about. And one of our particular focuses is on social function and thinking about how limitations in social function can cut across all of these different areas.
I agree with Dr. Pless-Kaiser. She named basically most of the issues that older adults face as they cross the mark of 60 and plus. So, but I would like to add also that I don't know if it's thanks to the rise of technology, which can be a blessing and a curse, we have also an increase of elder mistreatment and financial exploitation. And this is a major concern for our older veterans.
So Swords to Plowshares is a community-based organization. We're aging. We're celebrating our 50th year. So really looking at those health and mental health and behavioral health and the intersection with homelessness and poverty and barriers to getting care. We house over 500 veterans in permanent supportive housing, and I would say 65 to 70% of those are over the age of 55. Many of them age beyond their chronological years because of their experience. So, maintaining their health, protecting them from fraud and financial hardships, poverty, and allowing them to age in place. And then some very practical things like transportation and health maintenance and hygiene and, those sorts of practical considerations.
I'm Nathaniel Saltz with Minnesota Assistance Council for Veterans, and like Swords to Plowshares, we focus on the homeless veteran population. Our mission is to end veteran homelessness in Minnesota. So what you'll be hearing from me will also be from the lens of housing and homelessness. Some of what we see in our communities are veterans with high care needs and very complicated backgrounds to getting into housing, backgrounds that include felonies, evictions, what are not considered by public housing agencies to be standard household compositions. And so identifying appropriate housing opportunities and options for these veterans with their needs and backgrounds is one of the things that we really focus on quite a bit. Our what we offer and everything that we do falls within the categories of assisting veterans to obtain housing, finding doors, finding units that will accept them, to afford housing, and have the services and supports necessary to sustain housing.
Dr. Kaiser mentioned social function, and Dr. Hernandez Tejada, I was wondering if you could touch a little bit more on the ways that social engagement or social isolation can impact veterans' mental well-being as they get older.
Well, that's a very important question. I think actually social connections will say that that's one of the major concerns in older adults, and is sort of linked to everything related to their lives. Well, to all of us, particularly is impactful for older adults, but specifically for veterans, has a big impact because of all the risk factors that come from their service in the military when they were active duty. So what is the big impact of social connections or social isolation? So as we age, right, our social circles shrink, right? So aging friends and family pass away. Family naturally move from to different parts of the country. Some live in rural areas with less services. So social engagement is important because it provides different types of support. It may help reduce loneliness. It may help older veterans to engage in the services that they need and also foster a sense of belonging, right? So great social connections are also a protective factor against what I named before, that is elder mistreatment, abuse, and financial exploitation. Actually, we did a research in which we observed that people with great social connections recover better and faster from the negative outcomes of abuse compared to those who are isolated. So the thing is that in engaging in social activities are as easy as going to community centers, senior centers, engaging in sport activity of your preference, going to church, calling your friends or families via FaceTime or phone calls, or going to grocery stores. Now, there are more specific and targeted activities to help those aging veterans facing social isolation because of very specific factors. Many of those are physical limitations, mental health issues, lack of access to resources where they live, or lack of family living close to them. So then that's where us from the healthcare professions or the community partners that are concerned for the well-being of older groups, right, enter in the picture via more organized and targeted activities, either by support groups or one-on-one peer support programs. So for example, veterans engaging with other veterans through social events or peer support groups may help them maintain their identity and share experiences with those who understand the unique challenges of the military service. And in the end, this is going to bring very positive outcomes to manage symptoms of depression, anxiety, and PTSD. But remember, isolation can exacerbate mental and physical health conditions and may increase the risk of cognitive decline, and in some cases may increase the risk of other negative things in their lives. And falling into the hands of predatory people that are trying to take advantage of older people and their benefits, particularly in older veterans. So veterans with fewer social connections may also be less likely to seek help for their mental health, which worsens. They enter in this cycle of social isolation and mental health issues that never gets better. So I'm going to pass the baton to the rest of the panel, but I think addressing social isolation requires targeted interventions, education, promotion in our communities, and we have to use our technology to provide virtual support when it's needed, expand the access to veteran community centers and peer support programs, which, by the way, already exist in the VA healthcare system. And we also have to target things that are very basic and they are logistical in nature, like Amy named before, for instance, transportation.
I just wanted to add to that and say thank you and recognize that I think a multifaceted approach to helping with social connection is really important, because there's all these different areas, right, in ways to improve social connections, isolation, decrease loneliness, and that's all gonna have an impact, like you were saying, on physical health and mental health. I just wanted to share briefly a program that we're working on disseminating and evaluating. In the VA, we're working with some rural veteran partners funded through the Office of Rural Health, the VA Office of Rural Health. And it's a group-based intervention that we have. It's called Enhancing Social Function in Older Veterans with PTSD. That really focuses on the social function aspect. So it focuses on building the social support, interpersonal relationship aspects, values in relationships. It works on improving effective communication skills and talks about anger management and stress management type skills. And then building social support, recognizing some people may not have any or very few supports. And so we think about any of the different types of circles, whether that's other veterans or family members or friends or community partners. That could be supports and ways to build social activities like you're talking about. So part of the intervention is focusing on behavioral activation planning and goal setting around improving social activities, increasing that potential for support, and doing some goal setting around that. So it seems like that maps on really nicely to what you're talking about.
We see this having a very large impact on housing stability, as loneliness can make it much easier for somebody to become financially exploited. And if somebody's feeling lonely and they have a girlfriend online, we have residents that get catfished, and that's where the rent money goes every month. And we try to remember, as we're serving our veteran clients, that many are going to be fiercely independent. They're going to maybe resistant to services. But one of the strengths that we can take when working with this population, as we're striving to give empowerment and dignity, is that many of the veterans we serve love to have a task or a mission to accomplish that benefits the community. And so that's a way that we're able to get folks to start engaging in the community, not as something for them, but something that the veteran is able to provide to their neighbor, to somebody else in the community, to somebody else who needs it, and form relationships and bonds that way.
Overall, we're hearing that when we think about the aging veteran population, we are thinking about their physical health, their mental health, their financial and housing security, their engagement with community and with peers, and that all of these different factors are very interconnected. So we'll be sure to pull on these different threads. I'd like to start focusing a little bit more on issues related to housing security. And I know, Amy, that Swords to Plowshares is involved in the Veteran Support to Self-Reliance pilot out in California. I wondered if you could share a little bit about that project and how it could impact veterans in permanent supportive housing in the future.
Absolutely. So this is a 3-year pilot. It's funded, the governor funded it. It's administered through Calvet, and Swords to Plowshare serves as the design technical assistance and process evaluation consultant. And also we have a pilot within our own housing sites. The other pilot sites are at US Vets in LA and Inland Empire, Path in San Diego, Nation's Finest up north. And did I miss one? No, I don't think so. So the idea, and it's really out of our own experience, and Nathaniel, you'll definitely recognize this. In watching our own residents age, VASH and permanent supportive housing has been transformational in terms of getting veterans off the street. But, again, this isolation and just the intersection of their physical aging, their mental health, and their ability to to thrive, however they define that, is really difficult. So, we recognize that we just did not have the capacity to provide the on-site services that really would um, serve as an intervention to these issues. Um, so while the VASH caseworkers are great, they come, they're social workers, they really can't and shouldn't be involved in these kinds of hands-on supports like transportation specialists, service assistants, peer specialists. They should be social workers and do what they do. So the sites have a menu of staff that they can hire. Very importantly, these are employees of the housing site, the permanent supportive housing site, so that they can become a consistent part of the community. And it really takes a long time and an investment of time and money, quite frankly, to build that trust. So they'll see that person every day. They'll be in the van with the transportation specialist. There'll be activities for people to come out of their rooms and engage in. Peer specialists will knock on their doors. Maybe for a month they don't answer. Maybe in the second month they do. So, it's really this very intensive effort to build that community within housing and really counter, these really not so good outcomes that we're seeing, and ultimately we want people to be able to age in place. Some of these veterans, it may be their first home in years or decades, and it will probably be their last home. And we want to prevent exits, related to, if we can mitigate the aging process so they don't need a higher level of skilled nursing care, which is expensive and nobody wants it, and they want to stay where they live. They don't want to go off to someplace. Nobody wants that. Or, behavioral health issues or hoarding and habitability that would require, evictions based on the health and safety of other residents. So we have a very, very uh, comprehensive data collection. A lot of that is just observational and self-reported based on what access we have to information. And we will have an outside impact evaluator. And we hope that these types of services can be adopted nationwide within veteran permanent supportive housing so that these vets can age in place and really age with dignity and community and purpose.
Thank you. And you mentioned earlier, Amy, you touched on the idea that veterans, especially maybe who have had a chronic history of homelessness,
Mhm.
might be aging beyond their
Yes.
chronological age. I wondered if you could speak to that. And I know that this touches on your work as well with veterans experiencing homelessness.
Yeah, it was important for us that the eligibility for enrollment not be based on a specific age. So it's over 55 and or high acuity. Because a 50-year-old veteran, even, visually can, be manifesting the aging, of a 70-year-old. If you're talking about chronic homelessness, mental health, substance use, all of those issues. Um, Another thing, we have all of these issues piling on one another. So PTSD interferes with trust. So how do we get in there and offer those services and engage and create that community and overcome those trust issues? Experiencing homelessness really impacts trust. So, we have layer upon layer. So we really have to look at the individual veteran and, where they are in their life's journey, what their comorbidities are, and whether or not they need the help. It's not every veteran within our housing doesn't need or want these services, and every veteran who's enrolled doesn't need everything. They might want to use the transportation and engage in activities and talk to the peer specialist about the girlfriend online who's catfishing them, for example, but not need anybody to help with laundry or their room. So it's also they can, we can tailor the types of services. Also, any kind of group activities or engagement, we don't exclude people who are not enrolled because it's very much about building that community, breaking down that isolation, developing trust, and then getting to um, specific medical or social interventions to really help.
I think that's a good segue into my next question for the full group, which is that, I think for a lot of people, when they think of the aging veteran population, they might be thinking about Vietnam era veterans who are certainly a part of that population. But it's 2024. Some of the veterans who were present for the invasion of Iraq are now in their 50s. I'm curious what thoughts you have on what service providers should consider when they think about care for the post 9/11 veteran generation as they begin to age.
I think that's a great question. Actually, I was thinking as Amy was talking about the generations at some point in time, at least in our lifetime, they are going to join together in that aging group. So we have the baby boomers and we have the Gen Xers. So the baby boomers are between 60 and 78. We have the Gen Xers that all the Gen Xers are going to be 60 next year, by the way. And then we have the millennials joining around 2030, right? So 3 generations that are going to be together in this, right? So we cannot see aging as something that is happening to others or that is a little bit far from, from us. It's going to be sooner or later. So we need to prepare, I think we need to prepare for the millennials, which actually is the largest generation in history of this country. So what are we going to do when we have to have that many people in our system requiring services? So we need to start preparing. I think we have actually a very good foundation at the VA. And a lot of institutions are offering a lot of services. I think we have to focus precisely on social connections, on mental health, education in terms of what it means to engage in mental health. Because still there are groups in which mental health is seen as something negative, as something that it is a stigma. And so probably the stigma will not disappear 100%, but I think we can make it easier for the person that is suffering at that point of how they access care. So I think we have very good tools and skills in our hands to actually offer good services for people. The good thing is that the newer generations, they are more outspoken about mental health. So I think that we have to sort of like use that to educate our communities, in which it's okay to talk about it. But now how we are going to access, I think the biggest issue is how we are going to access this care. So we have to think about, for instance, women in the veteran population is increasing, and it is increasing on active duties and is going to increase on the veteran side. So how we are going to address the specific needs of women. So I can speak from the part research of what we have done. And actually last year we completed a trial in which we were integrating peer support within prolonged exposure therapy, which is one of the most effective type of treatments for PTSD. And one thing that we observed that we were not expecting that to happen is that most of our participants were women. So that tells you that there is it's more than 63%, which is usually goes against most of the studies in which we see, well, you know, in the military service, it is a widely male-dominated field. So the fact that we were not intentionally targeting women, but the recruitment shows that it was 63%. And the attractive part of it was, I think, that we were sort of like granting privacy because we were delivering fully via telemedicine or telemental health. And they had the support of another veteran. We were providing support in those parts that were most challenging for treatment. So I think that's why I insist we have to use technology and we have to use our social connections to provide better services, at least in mental health.
I have almost a question for Dr. Pleskaiser. Sorry, is that we see in, you know, post 9/11 era many multiple injuries, and how and I am not a doctor, but my understanding is that that increases the likelihood of dementia, early onset dementia, a lot of other health risks. So I think that, you know, in looking forward, we may have a population that overall is smaller among the much younger people, but have more complex issues that we'll have to deal with.
I think some of that may end up coming into being. I think part of it is trying to catch people earlier. So a lot of our older veterans now are, you know, did not have great experiences coming home or, you know, trying to get services through the VA, and have had really different experiences if they've come back more recently. And I think part of it, following up from what Dr. Hernandez Tejada was saying, is getting people coming in earlier, but also the workforce to be able to understand aging-related issues. So that well, part of your question, Amy, I think about multiple injuries. You know, if you think about the younger generation of veterans thinking about TBIs or, you know, cumulative traumatic events, leading to more difficulties with aging, right? Potentially. And we know that not only head injuries, but having chronic PTSD symptoms is related to higher risk for dementia and cognitive problems. So I think that's true, that we need to have like the people who are trained to be able to address these issues. And I know there's been calls for more geriatricians, more geropsychologists, more people who have aging-related training to address the increasing numbers of aging-related people and also aging veterans. Yeah. But I guess I would also just mention, I think, a little bit about the differences between the war cohorts. So some of what I mentioned about, you know, the homecoming experiences or the social support that Vietnam veterans, many of them didn't get, versus sort of how societally we're viewing veterans hopefully differently these days, but also things related to military experiences. So thinking about, you know, how people deployed by themselves and came back by themselves versus going over with their units and coming back with their units. We think about all the multiple deployments people are experiencing now. That's pretty different from the deployment experiences of older veterans. The diversity factor, right, in terms of more women, more racial and ethnic diversity in the military overall, but then also with regards to who got deployed, I think makes a difference. And even the types of combat exposures and war zone exposures, environmental toxic exposures, things like that, I think also all come into play in terms of how different generations of veterans may be impacted and how that affects their aging process. But I think we also think about the similarities, right? Like even though they might have differential experiences, we're still seeing, you know, high rates of mental health and physical health comorbidities, and how you might address that would be similar.
We feel between the different generations of deployments that our timeline for effective prevention of homelessness has shrunk. While services are definitely more responsive, I believe, now than they were back when the Vietnam conflict ended. In Minnesota, research has shown in our last statewide homeless study showed that veterans experiencing homelessness are an average of 10 years older than the overall adult population experiencing homelessness and become homeless a decade later in life. In Minnesota, we are a very big National Guard state. We don't have active duty bases for the most part, but folks were deployed older and leaving families and leaving careers, and then returning not as 19 or 20-year-olds, but often already closer to the age when veterans start experiencing homelessness on average in Minnesota. And so that's a shift that we've seen.
Dr. Hernandez-Tejada made a great tie-in actually to my next question, really connecting this younger generation of veterans with the growing population of women veterans. So I wanted to leave the door open if anyone has further thoughts on strategies for serving women veterans in your communities as they get older.
Well, something that I just wanted to add to emphasize the part of the stigma the mental health causes, especially for female veterans, and particularly when they are aging. And so in the context of military sexual trauma, which is even more stigmatizing, and it's very difficult to speak about it, particularly if you don't find those professionals in the medical setting where you're receiving your care that understands the challenges from your own service in the active duty or when this happens, and when you're trying to receive treatment. So we have to pay attention to address these needs. I think actually the VA has done a great job in trying to increase the number of clinics focusing on women, but we need to do more. And as a active duty and veteran female population are growing, and they are aging, and so we need more services, more clinics, more providers that the patients feel comfortable with, more social connections in the form of peer support, that peer supports or support groups in which they can speak freely about their needs. And this goes also for women in general population. So women are challenged, especially as they're getting older. They are usually the ones from in the context of abuse and mistreatment. The numbers are very representative in terms of the female population. So usually we have a tremendous amount of percentage of female in that are abused and that extend from domestic violence or from the type of service that they did, like female veterans, military sexual trauma. So I think we need to make sure that we address the issues that sometimes are very difficult to speak about, which is the abuse and exploitation, and these happen more frequently to women than men. So here at the UUT Health at Houston, the Trauma and Resilience Center, we actually have programs for all those groups, including veterans. So some veterans, either they don't qualify for the VA services or they prefer to receive their services somewhere else. So we have also services that we have different programs here for veterans, for women, for older adults. And the good thing about it is that we are using 100% elemental health, and so they can receive their services where they are at, where they prefer to see their provider, and at the time that they prefer. And that's a way that we are trying to use to reduce the stigma of mental health.
I'd like to touch on any best practices or adaptations that folks can share when they're serving the aging veteran population. And Nathaniel, if you don't mind going first, I know that MACV, at this point, nearly a majority of the veterans you're serving are in that older demographic. And I wonder how you've adapted some of your services in response to that change.
Sure, yeah. Right now, about 60% of the veterans experiencing homelessness in Minnesota are 55 or older. And so we do a number of things that focus specifically on this population. As we develop housing, and we've had some grants through the state of Minnesota, Department of Veterans Affairs to do this, we have really focused on getting units that are zero step or that we can make fully accessible for folks that need that. We have cultivated, we know we're not going to develop our way out of homelessness, but we could intentionally cultivate relationships with landlords so that if there's a poor tenancy that ends poorly, somebody leaves owing a lot of money, or it just goes south, that we don't lose the unit or the relationship with the landlord. And that may involve us spending some money that kind of falls outside of what typical federal grants will do to make the landlord whole again and to build our trust, the landlord's trust in us. And so that we can say, thank you so much. We're sorry this didn't work out. We have another veteran that really could use an accessible unit who has this felony background. Can we put this veteran in the unit now? And by having that relationship, we get to yes. Even though we just may have had a very bad experience with a certain tenant because the relationship is with us. And we do that very intentionally because we know that there's a lack of assisted living where veterans can go that have felony backgrounds to get those needs met. So we focus a lot on our healthcare navigation services to connect where possible with VA. We also know that we don't end veteran homelessness without working with veterans that are not VA eligible, and to make sure that those community connections are there, that folks are, whether they are or not eligible for VA, signed up for medical assistance, for Medicaid, Medicare, whatever their eligibility may be, so that they can get those waivered services, particularly those that can't get 24-hour care. So at least they're getting some of that at-home work that they need. One of the things that we found to be very successful is we've developed a partnership with a rep payee agency that we are able to pay what the veteran would normally pay every month. This was developed off of an SSVF pilot project. And so we have veterans that are willing to accept the rep payee for a few reasons. One, it's free to them. Two, we allow the mission is to provide as much choice and dignity and flexibility for the veterans funds as possible. So it's, what do you want to have come out of this? Your rent and your utilities. The rest is your choice. We're not trying to to paternalistically care for the rest of your money. And we've had many veterans that have felt really pressured every month. They don't know if this month they're going to pay their rent, but they're behind on their utilities, so they pay their utilities. And so this is such a stress. And maybe they don't know how to say no to family members that are asking them for money. And they don't have to now because they have a rep AE. And they can just take that deep breath and relax because they know that their basic needs for finance are going to be cared for with that. And the other thing we really do is look for subsidies and options outside of HUD-VASH. HUD-VASH is wonderful for many, many veterans. But if a veteran has certain backgrounds or if they don't have a positive discharge from the military, that's not going to serve them. So we've worked with our State Department of Veterans Affairs to develop subsidies that mirror VASH in many ways, but are designed for veterans that are not eligible for HUD-VASH or that are outside of the HUD-VASH service areas. And so this looking at that affordability, particularly folks with low fixed income, using our other subsidy programs, our ongoing support services, trying to develop communities where we do have our own housing and we can foster that sense of community, and building these relationships with landlords has really allowed us to, in Minneapolis, we've reduced veteran homelessness. We've cut it in half over the past 12 months and looking to become the 4th state to effectively end veteran homelessness. So I'm bragging. We just got the declaration for Minneapolis, Hennepin County this week that we met the benchmarks and criteria. But that doesn't mean the work is done, because we know that this is the population that is coming in our door and that we need to be able to continue to serve in better and better ways. So I'm actually really looking forward to learning more about this California pilot, and I'll ask you for some information on that.
Absolutely, anytime. I think also, in addition to those community services, like making sure you have a relationship with your local AAA Office on Aging Services or Department of Aging Services, other, local groups who work with aging populations, so that you can share those resources and educate one another, because as much as the VA resources are great, they do not cover everyone and they do not cover everything. The other thing is, I think, providing technical support and education for our personnel and staff about, for example, how do you, communicate or engage with someone who may be having cognitive issues, or especially like issues that they're not necessarily admitting that they have hearing loss or that they can't see or read. So how do you sort of, create that communication in a way that or see the like the clues that this might be going on, and that you do need to adapt your communications. Other things like falls prevention, the ability to have a little bit of extra funding to get things like, equipment for activities engagement. One of the pilot sites has, they bought yoga mats, they bought things like that, reachers, having, if you can't afford to have it on staff, some sort of arrangement with like occupational therapists. And then not only being able to engage with occupational therapists, but be able to do the follow-up, which is either reminding or helping the veteran engage in whatever follow-up they were prescribed, or if there is any equipment that's necessary to follow through. So those are just a couple things. Yeah.
And then if I could just add to that on the mental health side, in terms of at VA, older veterans are definitely being offered evidence-based treatments for PTSD because they're not contraindicated for older veterans. So that's something we try and do a lot of outreach and education about, as well as for other mental health disorders. And then at least some of the VAs have specialty geriatric mental health clinics that meet needs of older veterans, mental health wise. And we provide some training across geriatrics and geropsychology clinics to inform about trauma exposure and impact of trauma across the life course and trauma-focused treatment, so that our trainees can also meet those mental health needs. And we do a lot of outreach and training about providing trauma-focused treatment, evidence-based treatment, as well as trauma-informed care for older veterans. And just thinking about if modifications are needed. Sometimes, a lot of times they're not needed, but in some cases it may be helpful to pay attention to, how materials look or how information is delivered, or repeating information across sessions, or trying to include family members or a caregiver in treatment can also be really helpful. Or even just spacing out some of the information or the content of the sessions can be some of the modifications we think about.
I want to emphasize what Dr. Kaiser just said. That's super important. Even if you have services that, as she says, evidence-based treatments for PTSD, depression, anxiety in a clinic, like for instance, in a trauma resilience center, they exist. But if you don't personalize them or target a specific group, they don't seem to think that those that they are allowed or those services are for them. So it happened to us when we started finding ways to increase the population, for instance, of veterans, older adults in general. When we created the programs specifically for them, we had a tremendous increase. So for instance, for older adults, we used to have only 2 to 3 patients per year. And 5 years ago, when we established the older adult clinic, we went to 200 per year. So that's a tremendous change. The same thing with veterans. We have more than 300 veterans that we see per year in our clinic when we were not seeing anyone before. So it seems that people want to feel that, are these services for me? Yes, they are for you. But you have to also make sure that you promote the services specifically for them.
Thank you. These are great recommendations. And I've heard some examples of resources and partnerships outside of the VA system that are really helpful to keep in mind. For example, area agencies on aging, Medicaid, Medicare. I wanted to do a final call if anyone has a partnership or a external benefit or resource that they find really helpful that our partners should have in their toolkit as well.
I don't know how to rate, one, but we did just pull together a roundtable of aging services folks to come and spend an afternoon talking and just develop those relationships and connections and a listserv. And it was well worth the effort to do that and to maintain that communication.
But I wanted to turn to one or two questions from our audience before we end our discussion. The first question, since many older adult veterans suffer from loneliness and isolation, what are some strategies we can use to reach out to them in their isolated settings and connect them to the benefits they're entitled to?
That's a difficult one. Well, I strongly believe in community outreach. So you can have wonderful services, but if you don't go out in the community to promote them, nobody's going to know that you have those services. There are beautiful hidden gems out there that are fantastic, but sometimes they get lost or they disappear because of lack of promotion. So I think we need to have a dedicated, when we build these programs, we have to think of how people are going to find out about these programs. And we have to have people that are experts in community outreach to immerse in the community and to go out there and contact the stakeholders in the community. There are a lot of people that, it's not that they are gatekeepers, but they know exactly how to reach the population that you're trying to help and partner with them so you can promote the services. And that's the only way that people can get to the services. So once you do that, the change is significant of how you increase your population that are in need. And once the voice starts spreading out, just probably don't have to do much, but I think you have to keep always that community presence. I think people appreciate really that you go out there and talk to them about what you're doing, what you're offering.
We have a veteran community center. Again, transportation, you got to figure out wherever you are, but one is like, don't call it a senior center, don't call it adult daycare, don't call it mental health. Have food there. We have a pool table, we have a music room, and since we started it a little over a year ago, I think, time flies. There's word of mouth and more people are coming. Every day we have, you know, up to 50 veterans come through. They started, instead of just grabbing food and sitting in a corner, that they're engaging with one another. And then we have opportunities to do things like, financial counseling, or having attorneys come in to talk about VA claims, or programming. But, again, it's like you create this community space first, I think, or and what you call it makes a difference. So it's the Veteran Community Center. Yeah.
I think also in being innovative in how you try and reach people is helpful, and also offering virtual care. So like home-based programs, trying to get people together who might be more homebound but couldn't gather together in a virtual space. We developed a podcast to try and reach some rural veterans, to try and help them feel maybe less socially isolated by hearing other veterans' stories. And also partnering with community organizations. So we partnered with the National Hospice and Palliative Care Organization when we were working with thinking about veterans at end of life who had PTSD and are often seen in the community and not in VA. So trying to work with those organizations, or trying to reach rural veterans by reaching providers in rural areas who work with those rural veterans to kind of try and get the word out about the different services, because I think you're right, the dissemination piece can be really hard and is so important so that people can actually use the services that we've developed.
But we're approaching time, so I really just want to again thank our panel for lending their time and expertise. I want to thank everyone who attended our webinar today to understand more about this important topic. Our next webinar is on November 21st at 3 p.m. Eastern, and it will explore innovative approaches to cultivate social connectedness for veterans. So I think that's really a great follow-on to what we've been talking about here. We'll include the details and the registration link for that webinar in our follow-up email. Please share it with your colleagues and anyone else you know who might benefit from this information. But again, thanks to our panelists, thanks to our attendees.